Are we ready to begin?
I guess we should begin, yes.
Good morning, Erica, or evening. Hi, Fraser. Do you all want to do a little intro?
Sure. Yes, so hi everyone. Thank you so much for joining us today. This is one of a series of webinars we are providing under the TB Care 2 project. We've got a few more coming up, so keep an eye out for our emails. And otherwise, I will hand it over to the presenters, Lisa and Darcy.
All right. Thank you very much, everybody, for joining. It's wonderful to have you here. Today's webinar is going to be about lessons learned from pilot implementation of the Providing Comprehensive Supportive Care to People with DRTB. This is a project that was funded by USAID, and I was the lead consultant on that project. I'm going to give you just a brief overview of the actual framework for this project, and then we're going to hear today from Lisa Adams, Dr. Lisa Adams, who was our epidemiologist on the team. She's going to talk a little bit about our methods and how we structured the pilot project, and then we will hear from our colleagues in China and Pakistan about their results and the lessons they learned from implementing the care package. So we're very happy to have everyone here today. Next slide. I can't forward them. Thank you. So this is what we're going to do today. We're going to have a brief review of the framework for the care package, talk about the pilot project objectives and methods, describe implementation approaches and lessons learned in Pakistan and China, answer your questions, and give you some information on how to access the actual documents, which are now complete. Next slide. So this is just a little bit of a reminder about what the care package framework is. We presented this in the last webinar, so we're not going to go into great detail today, but there are 4 thematic areas that cover all of the different supportive services that people with MDR-TB might need. So the 4 areas are what we call respect for patient autonomy and support for self-efficacy, then maximizing physical comfort, safety, and wellness, so all of the physical things that cross over into some of the medical management, but are critically important to getting people through care. Providing psycho-emotional support and protection from social isolation or discrimination, so that covers all of the interventions that support people through their treatment, connect them with their peers, create legal frameworks to support them against discrimination, etc. And the final area is preventing catastrophic cost to patients and families. And within each of these 4 thematic areas, we have different what we call essential elements. So if you can hit the forward button. Sharanya. Thank you. Oh, 13. Sorry, 13. So underneath each one of these 4 thematic areas, we have these comprehensive care elements. The first element, the respecting patient autonomy, has 3 different components. One is creating a patient assessment and care plan at the very beginning of care and revisiting that throughout care to make sure that a patient's needs have not changed. So this is the way that we tailor the framework to individual patients. Then education and treatment literacy for the person with TB and his or her family, and being able to choose a location for treatment that is convenient for the person being treated. Then under maximizing physical comfort and safety, we have a number of different elements: monitoring and treatment for side effects, nutritional support for the patient, him or herself. So actually providing food supplements to the patient to improve response to treatment, monitoring and treatment of comorbid conditions, physical rehabilitation after cure for people who have experienced lasting side effects, such as vision issues or hearing issues, and palliative and end-of-life care for people who cannot be cured. Under psycho-emotional support and protection, we have Communication, respectful and compassionate communication. Mostly we're talking between providers of all types and patients themselves. Monitoring and treatment of mental illness, especially including depression, which is a big issue when we come to MDR-TB. Addressing social isolation and the need for emotional support. So this could be interventions like creating peer groups or providing a treatment supporter, and then protection from stigma and discrimination. And that would include activities to decrease stigma within the community, providing policies and legal frameworks for protection against discrimination. And then finally, under catastrophic costs for patients and families, we have providing financial assistance, and that could be either direct financial assistance, cash transfers, or indirect financial assistance, like providing food packages for the family. Next slide. Oh, and before we go on, just at the top of the screen there, you will see the URL that is linked to all these care package documents. So that includes the introductory document to the care package framework, as well as a workbook that you can use to implement the care package in your country. Next slide. So for the pilot project, we chose to do this in 4 of the priority countries for USAID out of the 10 overall priority countries. And those included China, they're the ones in orange here, Pakistan, Ukraine, and South Africa. So those are the 4 countries in which we tested this care package. So the first objective was to introduce all of these ancillary support services for people with drug-resistant TB, and then do an evaluation in terms of, is it feasible to implement? Is it acceptable to providers and patients? What was the level of patient satisfaction with the services they received under the care package? What were the treatment outcomes? So that's of course our ultimate measure is did it have an impact on treatment outcomes? And what did it cost to actually deliver the care package? So those were the things that we measured. And then we also wanted to look at the toolkit that we developed itself in terms of, was it useful to countries in planning, implementation, and evaluating these approaches, and how could we refine it for the future? And I see here that there's a message from our colleague in Cambodia saying that there is some noise. Ngak, I don't know if that's on your end or our end, but we'll do the best we can to make this as clear as possible. So on to the next slide. And yes, that's it. And I'm going to hand this over to Dr. Lisa Adams to go through the methods with us.
Great. Thank you, Darcy. And good morning, good day, and good evening to everyone. So glad that you all could join for this webinar. As Darcy mentioned, I'm just going to very briefly review the methods that we used. What did we do to assess the supportive care package that allowed us to obtain the results, which you'll be hearing about from the country teams in just a moment. So as Darcy mentioned, we employed methods to assess patient satisfaction with the package, feasibility and acceptability, and clinical outcomes. So next slide, please. So in terms of patient satisfaction, we surveyed patient cohorts before and after implementation of the care package. Specifically for the sort of before cohort, we obtained responses from a baseline cohort. That was a cohort that was at, receiving care at the pilot site before the care package was implemented. Or in cases where that was going to be tricky, we actually used a control cohort. That's a cohort of patients who were receiving care at a similar facility to the pilot site. And then, of course, we surveyed the cohort that received the care package after about 6 to 9 months of receiving care under the package. And then we compared those results. We were specifically interested, of course, in asking about overall satisfaction with their care, and then more specifically about their interactions with their providers and their attitudes towards their care and treatment, how optimistic they were about their care and their future, amongst other things that we surveyed. These are some of the things you're going to hear about, though, in the country presentations. In terms of feasibility and acceptability, we surveyed healthcare providers, or the frontline providers, as well as some of the healthcare managers, to help determine if the care package implementation was feasible at their site, what was the workload involved, what was the additional training that was involved, was this an acceptable implementation process, and was this a sustainable model? And you'll be hearing about these results in upcoming webinars. Next slide, please. And then, of course, treatment outcomes. As Darcy mentioned, what we really want to know is, does the care package lead to improved clinical outcomes for our patients? And to assess this information, we actually compared historical outcomes using programmatic data with what we had available, which were interim outcomes for the cohort receiving the care package. Remember that the pilot timeframe was about 6 to 9 months, so we weren't able to get final outcomes for all the patients during the pilot phase, though some of those patients were followed, and we will be receiving final treatment outcomes for the cohort that received care under the package. But this was the comparison that was done to help us assess the package, and again resulted in some of the lessons learned. So again, for the interim results, of course, what we would hope to see, the desired results would be that we would see a higher proportion of patients who are still on treatment at 6 months, using that almost as a proxy for having an eventual favorable outcome, that they would either complete treatment or be cured. A lower proportion of deaths, a lower proportion of patients that were lost to follow-up, and then again the higher treatment success rates as the final outcome. Next slide, please. So now we're going to hear some of these outcomes and some of the lessons learned from our country representatives. And we're very pleased to have 2 representatives. Li Ling will be starting us off with presenting some of the results and lessons learned from implementation at the sites in China. So I'll turn this over now to Li Ling.
Thank you, Lisa. Hello, everyone. This is Li Ling from FHI 360. So I will going to present this pilot result from China project. So please, next slide. Next. Hello. Yes. So you can see the so our project we call the CAP-TB project. It's a USAID funded project. At this pilot, during this pilot period, we have 6 sites from China participate in this pilot. Of course, you can see we also have the national TB program. They involved this pilot from the very first beginning. So next slides, please. So in order to deliver a comprehensive care package to our DRTB patients, we need to work not only with our TB doctors and nurses from our MDR-TB designated hospital, but also we need to work closely with our community health center. When patients discharged from the hospital, they have the most time in the community. So the community care workers, they play very important roles for the follow-up, also provide the injection services for them. So at the same time, we also set up the peer support group. The peer educators, they provide the online counseling or face-to-face counseling to our DRTB patients. Next, please. So the first, I will talk about the capacity building for our doctors. As you can see, the doctor is very important. They should have the appropriate regimen with the right dosage for our DRTB patients. Here we just list all of the trainings, workshop we have done for our doctors. The lesson and learn is for this part is we are not alone, work with, provide the care to our patients. We also need to give the orientation about the patient care center to our doctors, let them know what happened with the patient. So by seeing that, we have the weekly clinical case review led by our TB doctors. The nurse counselor will attend, also talk about our patients' feelings and everything. So next, please. Next one. So the next one is capacity building for our nurse and peer counselors. So we cannot, at the beginning we provide the training, but one training cannot really support them deliver a very good training. So very good counseling. So we call them come back to our demonstration site and also provide the on-the-job training for them. We also have an on-site. We also send the senior counselor to them, provide this on-site monitoring with them, and we also have the case review, difficult counseling case review. So that is by saying this, I just want to say that. You want to, have very good counselor. That is really a long way to go, and we need to, provide different support for them to provide good counseling. So the next one, please. So the next one, I would like to talk about the peer counselor. So we want to empowering all of the patients to become part of our care provider team. So we set up 5-7 rooms as is a peer lead online and face-to-face counseling platform. 5-7 rooms in Chinese, 5-7 means 5-7. That means never give up. This is led by our current or former DRTB patients. So we have our nurse counselor to training them, and also have the schedule for them to provide the online counseling and also face-to-face when they are in the hospital. So the lesson learned for us is we need work. The peer counselor group is very important. Actually, it's very important in this DRTB patient care package. We need to work with them as they are just a part of our, the delivery, this care team. So next one, please. So the next ones, we also developed different tools to support this implementation of this patient care. We provide this, for example, you can see the counseling tools. It's a patient treatment decision-making pathway. So the counselor will use these tools to explain to our patients what will happen if you choose a different role. For example, like in China, lots of patients, they trust the Chinese traditional medicine. We will use the tools to let them know. So to explain to them, if you choose not to, get the treatment now and go for the Chinese traditional medicine, and that one cannot cure our TB, sooner or later you will come back to us, and also at that time you may already infect your family member already. So that's all of the different tools, very popular and very useful for the counselors to provide the counseling to the patients. So the next one, please. So the next one is our, we would like to talk about the MDR-TB clinical management platform. So from this one, this is a platform. It contains all of the data elements that are required for clinical management in one location. So doctors, they have doctors and the counselors, they have everything in this platform, such as DST checks real drug regimen, clinical appointments with the reminder. We use this one to also look at how many people will come for the follow-up visit the next week. If they don't come up, then we will, immediately can contact with our CDC. So the CDC will coordinate with the community health center or village doctor to pay a home visit to see what happens with our patients. So from this platform, you also can see monitor whether our doctors give the right regimen and also the right dosage. So with this sputum test result, we show the patients it also motivates their treatment adherence. So next one, please. So for the whole pilots, we have a total 232 MDR-TB patients enroll this pilot. You can see, as Lisa mentioned before, this table is we have very encouraging results. So you can see the result is we look at the from last month, 2019. The treatment, the 60% of them completed their treatment. So, and we still have 23% still on the treatment. Compared with the historical 2015, at that time we only have 24 or 42% of the treatment success. And also we look at the lost follow-up. At the first pilot, play time, we have 8%, but after 1 year, we don't lose any patient. They all stay with us. So this is a very encouraging result, both for our patients and also our health provider as well. So the next one. Next one, please. Hello? Yes. So the last one is, so with this good results, as I mentioned in the first slides, NCTB from the first beginning, they involved in this project. So they saw the very good results, and they also saw this, encourage everything, the tools and the trainings and the capacity building for our doctor and the nurse and the peer counselors. NCTB plans to scale up this patient care model to all of the province within 2 years. They plan to have the lead sites per each one province. So the lead sites, later they can do the intra-province scale up by themselves. So with that, in this year, March, FHI 360 will sign an MOU with our Chinese CDC for the national scale up. Until last month, we scale up to 9 provinces and work with 26 local partners in China. So with this one, the last slides, I would like to thank the USAID provides the funding for us, and the core team, Lisa and Darcy, and guide us, and all of our friends. Thank you very much for your listening.
Okay, there we go. So now we're going to turn it over to Dr. Abdul Ghafoor, who is the MDR-TB advisor, technical advisor for Pakistan. And he is going to tell us about results in Pakistan and go into some detail about one particular intervention that they implemented as part of their care plan. Dr. Ghafoor.
Yeah, thank you, Darcy. I hope everybody hears me loud and clear. I'm thankful to USAID for engaging Pakistan in this important study and then providing us with the opportunity to talk to the colleagues about what happened and how successful was the study in this intervention. Next, please. This intervention started in April 2018, a bit delayed than other countries, and the study itself ended in September. 2018, with the objective of looking at the factors affecting adherence to treatment, and then to study the effects of intervention under the comprehensive care supportive care package on adherence and treatment outcomes. Like we had to look at the adherence and treatment outcomes, how much is affected by this intervention. Next, please. We had two PMDT sites, two sites for this study. One was Peshawar and the other was Murray. These two PMDT sites had number of MDR patients, and secondly, they have a long experience, more than a decade experience of treating MDR TB and much longer history of treating DSTB. So these were the two sites which were engaged in the study, and we had 50 patients each. A total number of 100 patients were engaged in this study. Next, please. And the project strategies, Darcy had been pointing towards these already. Patient satisfaction survey, we had to look at that pre and post, and then enhanced incentive for patients and supporters. Improved psychological assessment tool, nutrition support for patients, capacity building for psychologists, awareness for patients and supporters, home visits for contact screening and patient retrieval, and NTP, PTP support and supervision. And the project inputs were, but not limited to, increase human resource, development of modules and audiovisual ads, capacity building of staff, and as mentioned by our Chinese colleague, capacity building is a continuous process. So it was not only one training, it was a series of activities that were conducted. Cash incentives, family support and travels, nutritional supplements, and of course procurement, we had TV placed at every PMDT site with all the messages, audiovisual ads and audiovisual messages, and M&E supervision and program administration. Next, please. Next. Next, please. Please, yeah. Yeah, please hold on here. I mean, this is very important that I need to share that our focus, amongst many other things, remained on standardized psychological assessment tools and provision of psychological support. Our understanding in MDR-TB in Pakistan is that this is an area that needed more focus and more attention that we already provide them. So this study more focused on this psychosocial support, and as we will see, we found very good results with it. And of course, provision of health education to patients and families, distribution and use of appropriate health education materials, provision of food supplements to patients, provision of family support to patients, travel expenses to patient and treatment supporter. This was very important for us because the patient had to travel long distance, and because of this financial challenge, they would not be able to come to PMDT site. Provision of cost for ancillary drugs tests, like many tests like thyroid function tests are not done in the hospital, so they would not be able to do it in the market. So this study supported them in this, and we understood that it helps a lot. Monitoring adverse effects of drug, including cardiac effects, particularly while we are using drugs like bedaquiline and we were using drugs like clofazimine. Establishing the linkages between PMDT sites and the target districts, follow-up of patients' community to ensure adherence, and educating the family and the patient on infection control measures. Next, please. As I mentioned, we focused on, amongst other things, we will talk about depression and anxiety. I mean, these were the patients who were already on treatment. And when we started with the study, 32 patients had depression, and when we ended the study, the same only 4 patients had depression, a marked decline from 32 to 4. Similarly, 27 patients had anxiety that was reported and discussed, and through proper psychological support and counseling, the number came down to 2. Next, please. And patients' current attitudes towards their DRTB treatment is an important area of our concern. And if we look at this slide, we realize that almost all areas improved, like the hopefulness or the optimism of the patient increased remarkably, and the determination that the patient will improve remarkably. And the uncertainty whether they will, what will be the prognosis of the patient, what will happen to them. I mean, if you look at that, there 70% patients were not very clear what's going to happen, what's going to be the end result of their treatment. But when we end with the study, only 20% patients had this uncertainty. And so is depression of the situation, worried or being overwhelmed, angry at any given situation. Like if you look at these things, all of them improve remarkably with the proper psychosocial support and counseling. Next. And their attitude and their assessment of the provider, I mean, with the way things were conducted, like the one Lisa and Darcy referred to, and our Chinese colleague as well. I mean, they were, at the end of the study, they were very happy. And if you look at the slide that in front of us, almost 100% patients were happy with the provider. They were treated with respect. And they said that they were listened to, given proper listening. And those were the things that helped them complete the treatment. Next slide, please. Next. And I mean, this is the evaluation. If you look at that, almost more than 90% patient had satisfaction reported out at the end of the study, from almost 5% to 90%. Next. I mean, this is a very important slide that I'll draw your attention to. I mean, on the cohort, we had a percentage of 74%. And this is good for these two sites because I told you they got a long history of DRTB treatment, these two sites. Overall in Pakistan, the results are lower than 74%. But in our study, we saw that 47% patients, 47 had completed their study. Only if you compare death, like in the historical cohort, 19% patients died. In the under study, only 7% patients died. More importantly, loss to follow-up, though in these two PMDT sites, loss to follow-up was less. But with our study, with our intervention, there was not a single loss to follow-up, which is remarkable. And we expect that as the time goes on, we'll have a better treatment outcome than the historical cohorts, because as of now, we have got around 80% treatment success, those who have completed the treatment. And hopefully by the end of it, it will remain the same as the patients are now complete. They are almost at the end of their completion. So we'll be having better treatment outcomes. And with this loss to follow-up and low death, this remarkable achievement that the study has made. Next, please. Next. Again, the impact, we mentioned that 95% of the patients evaluation cohort with the respective PMDT sites, because they were properly supported, they were properly educated. Psychological state, providing psychological assessment and counseling had a significant impact on patient psychological well-being, overall mental health, and ability to cope with their DRTB diagnosis and treatment. Well-being, in addition to immediate benefits to patients, as we discussed, financial support helped DRTB patients overcome their financial challenges and crises. Travel incentives to DRTB patients also contributed to better adherence and positive attitudes towards their treatment and made their life easier to visit PMDT sites. I mean, a weight gain is an indicator of better treatment and better results. So 54% patients had documented weight gain. Next, please. Next. I mean, of course, like many studies have challenged, so did we. Selection of the patients, like choosing 50 patients among 150 patients is a challenge. So we address this by randomized selection. Disbursement of cash incentives, which is transparent and accessible, was a challenge, but we address it through a very transparent system. And difficult outreach, we engaged the local community for their support. And this local community support was not only for one patient, this was for the whole family. Psychological assessment capacity, of course, we didn't have that training material which was required. So we developed the training material, and we also developed the training and the capacity of the relevant staff. And of course, advised the MDR physician to introduce the patient care navigators to the patient, like I mean, the patient and the treatment coordinator, the navigator, as we called. Navigator was a person who would go to the patient's home to retrieve, to counsel, to advise them on infection control. Next. Next, please. I mean, the lesson learned overall was that psychosocial support is a very important component. Proper counseling, training of the physicians helps in patient adherence, better treatment outcomes, and incentivizing patients to reach to the PMDT sites helps. So does the incentives provided to the patient for addressing their challenges of financial challenges in home, better nutrition, better outcomes. Next, please. The structured counseling and lead to better adherence as evidenced by 0% loss to follow-up. I mean, I'm emphasizing the zero loss to follow-up as very important because this is a very important challenge in Pakistan. Regular interaction with the motivation of patients help engage them as ambassador of DRTB services. This was particularly done at two PMDT sites because we thought that those who are treated for DRTB patients can be very good ambassadors. And that's something we managed to do, and some of them are very useful ambassador of DRTB services now. And we say the coordination with the community plays a very important role in addressing stigma and advocacy. And TB control programs should include psychosocial support, structured counseling, travel incentives in their proposals. Next, please. Next. I mean, this is the last of the slides. What are we going to do is we are going to disseminate the evidence to the relevant quarters with the partners, all of partners, and the government at the highest level. Advocacy at highest level for political buy-in. This is very important because in the next year, the next few months, we are developing national strategic plan, and this study will help us in incorporating these lessons learned and these interventions in our national strategic plan. Adaptation and use of materials developed through pilot awareness, video, physiological, psychological assessment tools. These all will become part of the DRTB services that are being done in Pakistan. Domestic funding through social protection initiative. There's an initiative going on in Pakistan. We call it Health Card Scheme, and Asas, recently is the name given to it. So NTP is now planning to engage these organizations which can support the patients. Explore local philanthropy through Stop TB Partnership and other activist organizations. Technical assistance from international partners for advocacy and resource generation. Revision of NSP 2020 and inclusion of lesson learned from comprehensive package for MDR TB. There, thank you. And
all right, thanks very much, Dr. Ghafoor. I appreciate that description, and I just want to end this by saying thank you to the entire team who worked on this project. First and foremost to Alex Golubkov, who was our focal point at USAID leading this project, and our team, including Lisa and Dr. Hilton Lamb, who was our economist on the project, our two interns, Carolyn Rodebeck and Nuha Nakri, and especially all of our implementing partners and the national TB programs in the 4 countries where we did this pilot. And today you've only gotten a very brief overview of what was a huge amount of work on their part. We will be producing reports for each of the countries. They're in the final process of being edited right now with much more detail about the implementation plans and the results. So stay tuned for access to those. And in addition, we will be having, as we said at the beginning, several webinars to talk a little bit more about what we learned from this project and how to go about implementing this project at the national and facility and local level. So stay tuned for those. And we now have time for questions. So I will turn it over to URC to help guide us through that.
Yes. Hi. And while we ask you guys some questions, please do take the time to fill out a small poll so we can get some feedback on this webinar. The first question is to Dr. Abdul Ghafoor. Sunita was asking, what were the strategies with depressed and anxiety patients other than psychosocial support?
Yep. Like psychosocial support was one important component of it. But the other thing that we did was peer counseling, peer groups, making formation of peer groups at the PMTT sites. And secondly, community engagement, our navigator and sometimes physician would go to the community, talk to the patient and talk to the community so that they would be engaged in destigmatizing the issue, number one, and secondly, providing confidence to the patient and to the community that well, with proper treatment, they can be helpful. So, of course, we are providing them with also other support, standard DRTB care support. Almost all of it they were being provided. But so psychosocial support was an important component of ours, and peer groups, community visits, community engagement. These are by and large, I think. Otherwise, there can be a lot of details to it.
I also see another comment in the chat saying, in this lecture, we learned financial support and supplemental nutrition were crucial for MDR-TB patients. And that was absolutely true in Pakistan and in some of the other countries as well. But I just want to say to people, when you go back and you look at the framework, the whole point of the framework and thinking about these 13 essential elements of care, the comprehensive elements of care, is that depending on your location, depending on what's feasible in your country, depending on the patient population that you have, and depending on the individual person whom you're treating, the relative importance of those 13 areas may change. And that's the whole point of the care package, and especially the care plan itself, that you have the ability to tailor this set of interventions that you've developed to each particular person and that person's needs, because not everybody will need everything that you can provide. So it's important for you to think about your own populations and your own individual patients as you create a care plan for them.
Darcy, may I add something about this part?
Sure.
Yes. So it's yes, I just want to talk about my care plan. From that part, because from our experience in China, under the Global Fund, the patient will get like a transportation fee for them, for the comeback, for the follow-up. So they also some nutrition support with the cash or with the food. But we use from our pilot project, we use the care plan to guide us to conduct assessment to see whether this patient really needs. Because some patients, they may not need this one. So that one is then we have a discussion with the peer counselor and the nurse counselor. They can make a decision and to better, provide the, like for example, like transportation fee for the patient who are really needed. It's not for everyone. Thank you, Darcy.
Thank you. I also see a couple of other comments and questions here. Teresa Rugg reminded us that there are 2 very good international resources for peer TB support groups on Facebook. So TB Voices from TB Photo Voice, which I encourage everybody to look at, and TB Support Private Support. I don't know that one, but thank you very much for sharing that information. There is a link on the chat to the recordings of these presentations and the slides themselves, so please use that. Fraser commented, fascinating and shows good care gets good outcomes. Having costing exercises done to show that the investment into such care is worth it. Yes. So we will talk about that in a future webinar, I hope, Fraser. We did a cost analysis. It's not perfect because it's very complicated and we had a limited budget to do some of the costing work, but what we found in general was that implementing the care package in these 4 very different settings with 4 very different sets of interventions cost somewhere between $40 per month per patient and $150 per month per patient, depending on where you are. But we did look at the relative economic benefits versus the relative costs. And in all of the countries where we did this project, it improved the cost efficiency of care by implementing the care package, because more people were completing treatment, fewer people were dying, fewer people were transmitting and resulting in additional cases. So we will cover that in a future webinar. David says, what would you say to those who may think only a randomized controlled trial would prove the efficacy of this approach? What would you say to skepticism about this? Well, obviously we were implementing under programmatic conditions. That's not a perfect study design, perhaps, but I think in all cases we saw some very marked improvements. And I would say that in addition to the actual improvements in patient outcomes and patient satisfaction, what we heard from our countries was that this was an important piece of quality improvement in their care provision, so that there were a lot of secondary health systems benefits to implementing the care package, including improving the linkages between facility-based care and community-based care, organizing the care, excuse me, within facilities so that it was more efficient. So a lot of countries developed SOPs. There was a much clearer division of labor. People knew who were supposed to be responsible for different pieces of the care package. So this is a way of systematizing what you're doing. In a lot of countries, you're already working on patient care interventions. This is not designed to replace that. This is designed to give you a way to organize that and see where you may have gaps so that you can fill them in a systematic way, prioritizing what is important in your setting for your populations. So yes, it's not a perfect study, but I think the results are quite encouraging, and I would challenge anybody to say that we're not moving in the right direction with trying to be more person-centered and use a rights-based approach to care.
Mm-hmm. And Darcy, if I can,
please,
if I can just chime in as well. And we discussed whether using a randomized controlled trial approach would be optimal or not. And I think obviously the challenge is that there's questions about, is our control group as ideal or optimal as it could be? And I think we really did strive to find what we considered to be the best comparable patient cohort as a control, recognizing it's not perfect. But I think what Darcy said about wanting to show that we could implement this under programmatic conditions was, we felt much more critical than trying to create an artificial study design setting where things are often different than when in randomized controlled trials than when you go to implement it in a programmatic setting. And we were really committed to showing that this could be done anywhere under programmatic conditions for the practical, logistical reasons. And I think that the value of showing it in that setting really far outweighs trying to create an artificial controlled trial setting.
Yeah, thank you, Lisa. I think that's really important. There's a question here for Dr. Ghafour, and sorry, because I know that there are other questions, and if you have a question, please use the Q&A section to ask your questions so that we have them not in the chat but in the questions. There's a question from David Bryden for Dr. Ghafour. For those suffering depression or psychosis, was there medication for those conditions available?
Yeah, I mean, this is a very important question because this study itself provided support for the provision of medicines which were required. Like, I mean, they were sent for a one was psychologist counseling, and then psychiatrist opinion, those who are in depression. So all the prescriptions were supported by this study, and patients received the relevant treatment.
Thank you. Okay, there's one more question in the chat, and then we're going to go over to the Q&A. In the 2 pilot sites, how were catastrophic costs measured? We didn't measure catastrophic costs per se. What we measured in this particular pilot was how much did it cost to implement the intervention from the health systems side. So in the countries where we had some information about the out-of-pocket costs, we included that. In countries where we didn't have that, we didn't include it. So the cost piece is the most challenging, but we will include a discussion of the cost in future webinars, and it's also discussed in the actual the hard copy reports that will be produced, and those are in final edit, as I said before. So stay tuned for that, and we can also have offline discussions. If you're more interested in the cost, we can share that information with you in the future by email. And one more question from David, and are you hopeful that countries may include this approach in their proposals to Global Fund, and do you think the fund will respond positively to this? The answer to both questions is yes, and we did consult with Global Fund in putting together the framework for the care package. So that was quite a long process of consultation with people who had experience of going through MDR-TB treatment, frontline providers, implementing partners, donors, as well, including Global Fund. So everybody was invited to comment on the framework, and we are sharing the results with them. We hope that there will be a positive response, and it's certainly something you may want to consider as you think about moving forward and how to fund this, is to include comprehensive patient care in Global Fund proposals now that we have some data to share that seems relatively convincing that this can help with treatment outcomes, especially in countries where you're seeing challenges with patient outcomes. Okay, so then we have, okay, while providing, I'm just looking at the questions now. Question: while providing care to DRTB patient, one of the immediate needs is nutrition because cash transfer will take time. How did you all manage to do this? Dr. Gafoor, do you want to answer that question?
Yeah, sure. We developed a system of cash transaction. That was a bit complex in the start, but with the time we facilitated the process in a way which was patient friendly and like the system friendly as well. But in addition to that, we provided nutritional support with the financial support. Like we would provide them and ensure like some provision of nutrition as well, along with the financial support. So we would be sure that the finances that we are giving to them are can be used if at all elsewhere, but the food provision should be ensured that the patient should have better quality of food along with these complex treatment. So yes, we provided them with both, with nutrition support as well as financial support. And financial support can be made easy. Like, I mean, depending upon every country's own systems, but that is possible, and that has been done in Pakistan successfully.
Thank you. Then there is a question from Edie. How do you select eligible patients to receive financial support? Li Ling, do you want to answer that question?
Yes, yes. So that is for this one is we use the care plan and to see like how whether these people have a job and what's the income for them, and also so we look at any social supports they can get from us, from this family member or friends. So we actually just use the patient care that's checklist to see, and once we identify patient who needs the financial support, they will bring to the team, the deliver team, which will contain the counselor from the peer counselor and also nurse team and also doctors to discuss how much we can use. In China, we actually set an emergency fund for these people. It's not for everyone, it's for those patients we conduct assessments.
Mm-hmm. So I think that's a really important point to emphasize, that every patient is different. So it's important, and it's part of the care plan, which is included. There's a standard generic template for a care plan included in the DRTB care package documents, and so you can download that and look at it and adapt it to your own settings. Every country adapted it differently and uses it in a different way, but that's the patient assessment is a critical part of establishing a therapeutic relationship with your patients at the very beginning of treatment, but also understanding very clearly what it is they need and want. So I would encourage you to use something like that with your patients as you enroll them on treatment. Dennis says this study is essential to obtain patient perspective and compare the treatment outcomes. I suggest to study healthcare workers on delivering quality care, as this may affect the results too. It definitely did, Dennis. I don't know if Dr. Gafoor or Li Ling want to comment on this, but we do talk about some of the health systems benefits and some of the responses that we got from healthcare workers. We did survey them as part of the outcomes for the project, and those results are reported in the country specific and the overall report from the pilot that will be available soon. Li Ling or Dr. Gafoor, do you have something you want to add?
I mean, just add a brief comment that when the patients are happy, when the patients are being provided with better support and more comprehensively, what we observed was that despite adding to their work, physicians and the healthcare workers and healthcare providers were happier and more satisfied than they would otherwise be. Like, for example, if they don't have money for a prescription or for filling in a prescription, they would be rather stressed. But in this situation, we found them that even adding to their work, they would be more comfortable and happier. And that was shown with our study that we did on the physicians later on, the physicians and healthcare workers. They were satisfied, they were happy, and they could provide time for this, even without additional incentives.
Yeah, excellent, thank you. There are a number of different questions. I don't know if we'll be able to get to all of them in the next 3 minutes. I have to get off at 7 because I have another conference call, but we'll do our best to follow up on the questions we didn't get to answer during the webinar by email. And there's another question about, were there any DRTB patients with HIV co-infection? What were the treatment outcomes among them? That was certainly the case in South Africa. We're going to hear from South Africa in our webinar on implementing the care package at the facility and community levels. So we can talk a little bit about that then. The short answer is that those with HIV co-infection did not fare any worse than the other patients in that cohort. But there are lots of things to discuss about that, so we'll save that for another webinar. Alternative mechanisms for disbursement of cash incentives, how was this done? More detail, please. There is more detail in the individual country reports. Dr. Gafoor, do you want to say something briefly about that?
Yeah, I mean, we had to try so many methods initially. Like we went through all the system that we had in Pakistan, but ultimately we realized that, well, transferring it through cash, through a properly transparent system would be more appropriate than asking the patient to going through complex banking systems. So yes, we analyzed all the available opportunities, and then we went for the best and the simplest.
Okay, very good. There is another comment here about nutritional support is given to patients. It's often shared with family members in many cultures. This is something we need to understand and tailor the strategy and educate family members. That's certainly the case. And what we did in this pilot and in the framework itself is we separated out the nutritional support given to patients themselves to improve their response to treatment from the support that would be given to families as part of the trying to avoid catastrophic costs. So that was indirect, that was under indirect financial support, which is part of comprehensive element 13, whereas the nutritional support to patients is actually a different element under physical comfort and safety. So that's one of the ways that we try to distinguish between those two things in thinking about how to craft the framework. Okay, and it is now 7 a.m. my time, and unfortunately I need to get off.
Darcy, thank you so much, as well as to Lisa and Li-Ling and Dr. Gafour for joining us for this presentation and leading it. As we said before, this webinar is a series of webinars being offered by TB Care 2 and URC, and I would just like to hand it over to Dr. Neeraj Kak for an announcement.
Thanks. I just wanted to make a quick announcement. I saw some of the questions that were deeper about cost analysis, and also, as you know, many countries are moving through universal health coverage, national health insurance plans. URC is planning to host a webinar towards the end of September on UHC and NHI integration. So we'll send out an invite for that also. So we'll continue the discussions, because this is very important that we also give some ideas about how do we broaden NHI's integration of TB, which includes not only clinical care, but then also all the other elements that were presented today in the TB care package. So that's, thank you very much.
Yeah, thanks to everybody for joining, and in subsequent webinars we'll be hearing some of the results from Ukraine and South Africa as well, so stay tuned.
And for the unanswered questions, we will try and get back to you by email. Thank you so much, everyone, for joining us today.
Thank you.
Thank you all.
Good luck to everyone.
Bye.